Good morning or good afternoon, depending on where you're joining us from. I'm Deanna Helscher, and I am the Regional Dean of the Austin UT Health School of Public Health, Houston campus. So I'm really happy to welcome you to today's lecture. So the webinar today is sponsored by the Michael and Susan Dell Center for Healthy Living. And so our vision is healthy children in a healthy world. And you can't have healthy children without healthy parents and healthy communities. So the lecture we're going to have today really fits in that model. So our mission is we advance health and healthy living for children and families through research, innovative community-based programs, and dissemination of evidence-based practices. And once again, you'll hear that on today's presentation. So just to let you know, this webinar is part of a series of webinars that we do periodically. And if you want, you can go on our center website, which is msdcenter.org, and you can access our resources. And they include, in addition to the webinars, we have a newsletter, we have expert blogs, social media, research and resource stations where you can see all our projects, our Texas Health Status reports and toolkits, and then our Texas Research to Policy Collaboration Project. So the presentation today is accepted for contact hours of nursing professional development. So to attain these nursing CEUs, you need to attend the session today. You also need to complete the online evaluation form. And so we'll have a QR code that you can access. So Cizik School of Nursing at UT Health Houston is accredited as a provider of nursing continuing professional development by the American Nurses Credentialing Centers Commission on Accreditation. Neither the planning committee members nor the presenters today have disclosed any relevant financial relationships related to the planning or implementation of the CNE activity. We have no conflicts of interest to disclose to you. So we are required to report perceived bias, and commercial bias may occur when a CNE activity promotes one or more products, which include drugs, devices, services, software, and so on. The ANCC COA is interested in the opinion and perceptions of participants at CNE activities. Today's evaluation form will ask you to inform us of any perceived bias that you might see in the presentation today. And with that, I'd like to introduce our speaker, Dr. Christopher Greeley, and he will be presenting on a really innovative program that he's doing for maternal mental health. Dr. Greeley?
Excellent. Thank you so much, Dean Heschler. I'm very excited to be part of this. I've been a fanboy of the center for many, many years, and so I'm excited to be allowed to talk a little bit about some of the work we're doing. So I am the chief of the Division of Public Health Pediatrics at Baylor College of Medicine and Texas Children's Hospital. I'm a pediatrician, and my focus of our division is largely on family vulnerabilities, children and mother vulnerabilities. We have a clinical service, and then we have a public health community-based service. And a lot of the work that I'm going to talk about today is all based upon our community-based work. And I present this on behalf of the team. The team does all the hard work, does all the really exciting, impactful work, and I get to sit on the sidelines and watch them do phenomenal work. And we have a spectrum of people, from doctors of public health to PhDs to social workers to community health workers to home visiting nurses. And I want to go through some of the stuff that we've done that has been largely focused on improving the trajectory of kids and moms related to pregnancy, healthy birth, and healthy infancy. And so as a overall, we have a suite of programs called upSTART, and upSTART is intended to be taking the start of a mother-baby relationship, taking the start of a baby's life, and improving its trajectory, doing what we can do to support the baby, to support the mom. And there's a specific component that I wanted to talk a little bit in some detail today called upLIFT. You can see that much like Apple with the I, a lot of our programs have up beforehand because our framing is everything is going to be positive in the upward trajectory. So upLIFT, I'm going to get into details about what that actual program is and what are the things that we do in that program. So our big picture is we have a large suite of programs. A lot of these are all of them are community-based, all of them are free, and a lot of them are home-based, where we have people going to people's houses, or community-based, where we meet at a YMCA or a local library. And what I'm going to focus on today is this one program. I'm going to talk a little bit at the end about the rest and how they all fit together, but I'm going to focus on upLIFT. And upLIFT is a home visiting model for mothers with peripartum mood disorder, pregnancy-related mood disorder. Mostly it started with postpartum depression. So I'm going to start with how this came up, how we came up with this. And if you look at all of our programs, all of them, with the exception of Nurse Family Partnership, were community-based, collaborative, that we developed, and we were able to then partner with our community partners to be able to develop, to deploy these for our families in the greater Houston region. And so I'm going to focus on upLIFT because it is related to postpartum depression and peripartum mood disorder. And so the history, I want to give a little bit of history because I think it's helpful to see if you're in your community, you see problems, you can see how we developed this and how this came up. And it really is, I think, a quite nice trajectory. So we started with really the basics of a needs assessment. In 2014, I was at UT right down the street, our partner institution, and I had, with colleagues, started a Center for Parenting and Family Wellbeing, and two of the people, Beth Van Horn and Nancy Correa, were at that center, and we were really interested in looking at what is the landscape in Houston for postpartum depression. How do we recognize where the gaps are? Where do we need to focus on service that we wanted to do? So we actually did a needs assessment, we used Texas data, we used Harris County data, and we identified that there were about 70,000 births. Again, I'm going to give you some of the background to see how we came up with this, which really highlighted to us about 13,000 moms every year just in Harris County will approach the diagnosis of postpartum depression. And so we looked at this. This is a public health. To us, it said this is a public health need. And if we looked at our most recent data, at the time, this was now, you can see 13 years ago, we saw a large percentage of moms, again, these are females, 15 to 44, admitted for mental health disorders. And the very bottom one, you can see 1,300 women every year. You can see the trajectory, the very bottom line going up. More and more women every year were being admitted to the hospital for perinatal mood disorders. And we sort of saw this as we need to learn more on what we can do. And so we started the Division of Public Health within Baylor College of Medicine and Texas Children's Hospital in 2015. And our first focus was postpartum depression. We wanted to learn about postpartum depression and how do we recognize where their gaps are, and how do we develop strategies to respond to those gaps. And so we did a secret Santa phone call. We had our female employees called all of those listed on all the insurance plans, Medicaid, all the commercial private insurance, and we called them and said, my doctor just told me I have postpartum depression. Can I seek care? And so we found 51 spots in the greater Houston area that would serve moms with postpartum depression. We then asked, do you accept Medicaid? And then we dropped down from 51. We then said, do you take Healthy Texas Women? Again, at the time, that was something that was new. And we were looking at what is the access for low resource moms? Who can be seen within 2 weeks? So it's not just that you're available, but you are timely, that you can be seen within 2 weeks. And then lastly, who speaks a language other than English. And so we went from 51 to 15. And so all of a sudden, a high-risk population for postpartum depression, again, the rates of admission to the hospital had been going up. This high-risk population, you could see, had sort of relatively limited resources. And so we then looked at the data that we had from Texas Children's Hospital. Again, we published a lot of the data, and I'll show you our references. And so Texas Children's Hospital had begun to do universal screening in the OB and pediatric offices using the Edinburgh postpartum depression screens. And you can see we published on 100,000 Edinburgh scores. We looked at over about 4 years, 5 years, what were the scores and who received care, because everybody was on the same electronic health record. We could see who scored positive, who was referred, and who actually received care. And so 102,000 Edinburgh scores, we identified that across the board in a large sample size like that, about 6 to 8% were positive. No matter where they were screened, about the same rate was positive in the pediatric office and the OB office. And we identified within our population, we now have a better sense of the risk, meaning our population is the Houston area, and our subpopulation is those that are receiving care through a Texas Children's Hospital pediatric office or OB office. And then we were really particularly interested in who actually received care. And so you look at the end here, and these I think was really what inspired us to develop a program. If you had, again, these were OB offices, if you had integrated mental health services, and that means part of your visit, your standard visit for peripartum and antepartum care was a mental health provider, 82% of women who were positive received treatment for that postpartum depression. If it were co-located, which means they're in your office, but they're not part of the actual visit, you can see almost the same. So if you have a mental health provider as part of your care, integrated into your office or integrated into the visit, 80% of women who screen positive will receive care. What we found, though, if you were adjacently located, which means they're in the same building, but not part of your office and not part, you all of a sudden drop to 40%. And if it's coordinated, which means here's a number of someone to call, you can see 20%. So we could see that there was this gap. There was a service gap, that there were women who were positive. And you can see that those were the pediatric offices. There were 80,000 screens that were done, and about 6% were positive, but only 20% got care. And that we saw that as that was our target. There's a population of women we know who have a condition that is amenable to intervention, but were not seeking care. So we ended up developing a model for postpartum depression home visiting, and we then found funding for it. We piloted to pilot home visiting versus a psychiatric referral. And so we actually ended up getting funded by the Texas Medical Center Health Policy Institute. At the time, it was looking for funding on disparities to access to care. And we ended up getting about $100,000 to pilot a randomized controlled trial, a non-inferiority randomized controlled trial, again, high quality scientific methodology to say, can we fill this gap? And it really was a very basic. Women that come in that have a score between 10 and 20 got randomized. Do you get a referral to a psychiatrist, or do you get a referral to a home visiting social worker? And that was what we ended up doing. We published it. We did a randomized trial, non-inferiority trial, and we published it in, you can see in Health and Social Care. And so what we ended up finding is we had this study. We had about 800 eligible people. About 150 consented, they were randomized, and because of dropout, we had about 91 and 65 in the two groups. And at the end, we had a much smaller sample size because this was when COVID was coming. So our study was sort of interrupted with COVID. A sample size was much smaller than we anticipated. We wanted to have 150. That was what our power calculation was. But we got less than that, but we still thought it was meaningful because there were some significant findings, and it was very informative to us. And so what did we end up doing? First and foremost, when you look at the referral, these are the number of completed visits. You can see at the very top line, 35% of women referred to psychiatrists didn't get any care at all. they were randomized into referral psychiatry, we didn't, but only 4% of women who were referred to a home visiting social worker didn't get care. So you can see right there, there is discordant at the very front. It was palatable to have a home visiting nurse come to you. You see at the very bottom, who completed treatment? 13% of the women in psychiatry got 5 or more visits, where 50% of the women in the home visiting. So you can see it was not just palatable, but more people finished their treatment course when they had a home visiting nurse. And we thought that was a really informative. So it was palatable. People will see this through. We looked at the scores. This is Edinburgh at 6 months after delivery. And you can see the top line, the orange line, is those who are referred to a psychiatrist, and the bottom line, the blue, home visitors. And what did we see? Everybody got better. The overall change was everybody got better. But importantly, the p-value of 0.31 tells us that home visiting by a social worker was no different than a psychiatrist. That to us was really what we wanted to show, that it wasn't harmful. It wasn't harmful. You weren't ignoring women. You were actually delivering care, and it was no worse than what you were already doing. That was our, again, non-inferiority. We wanted to show that this wasn't dangerous, and we weren't thinking that we were going to make them worse. Again, that's our researcher equipoise. We start with, is it harmful, is it effective, or is it ineffective? And so we found it was really heartening to us that this was worth pursuing because it wasn't worse than standard of care. We also saw that, for example, the postpartum bonding scores were also no different. So they bonded a little better. But what we did find is our standardized maternal self-efficacy scores for the moms who got social workers were statistically better than a psychiatrist. So social workers going to the house address things that at the end make moms say, I feel like I'm a better mom now. And to us, that was really valuable. It's no worse from their depression standpoint, but from their am I a good mom standpoint, it was actually better than this current standard. So we were really heartened by this, that this was no worse and in some ways perhaps even better than the current standard of care. And so we then ended up saying, let's start exploring this. Let's start developing it. So our models really started with some early consultation with the maternal psychiatrist and a maternal psychologist. And the idea is, you may not be able to see this, was we tailored it to what were the needs of the moms. So if the mom said that your emotions are a roller coaster, we would then have some form of emotional regulation. And then we'd have modules that were tailored to, each of the visits were tailored to what does mom's need right now. And if mom said to us that, my worries, I have lots of worries and it stops me from sleeping, we then had a very targeted CBT therapy. Again, this isn't therapy, but this was a treatment model that could address some of the immediate needs. We then had consultation, again, with our colleagues at the Menninger Clinic, a maternal peripartum psychiatrist and a maternal peripartum psychologist that helped us begin to develop new modules, develop the content. And then we were funded by the state to develop the larger picture, the upSTART picture. And this was one of our key components, was this home visiting. The upSTART picture, again, the big model, is a multi-component, community-based maternal and family support system. It's multidisciplinary. There are some physicians. It's largely not physicians. There's nurses, community health workers, social workers, all of this. It's ecologically based. It's modular, so families can get pieces, not the whole thing. They can get what they need. It's all based upon positive skill building. And one of our big focus areas is early brain development. We wanted to really have this be the unifying theme, is helping moms, but really focusing on the baby's brain development, because the data show that it was predictive of long-term outcomes. And so this is what we proposed to the state. This was funded by at the time, Department of Family and Protective Services and the Prevention Early Intervention Division. And we had families that were at risk. We would then intake them, find out what their needs are, and then deploy them to what services they need. The one that we Some of this were community partners. So we had nonprofits that were already doing things. So we said, we don't have to do it. We'll just screen them and then we'll give them to you. So we had warm handoffs where we weren't doing all of it. We didn't want to do all of it. If someone's already doing it, we don't have to do it ourselves, but we need to have a team approach. And then part of this is, again, this is what we submitted to the state for our early funding, was, parental mental health. Like, that was an important component to the child's outcome. And that was what we developed. And that was where we started really expanding what our upLIFT model was. So we launched, after we got funded, more broadly, not just from a piloting perspective, but more broadly, the upLIFT home visiting model. So this is the upLIFT home visiting model. And this is home visitor, a licensed social worker, up to 8 one-hour sessions in person, but sometimes if people are busy and they don't want you to come to the house or something like that, we'll do it virtually as well, in English and in Spanish, at no cost to the mother. And we have these 16 individualized modules that we developed and then had over an iterative process. Our home visitors would come back and say, this worked and this didn't work. And our maternal psychiatrist and maternal psychologist were saying, great, let's try this, let's tweak this. So this was an iterative process. Again, all we developed was for, again, informed by the evidence that was available. And then part of this is we also developed something for groups, because we really felt that the social capital, the idea of being bonded with other people, would be valuable, and a teen program, because the content was a little different for teens. And so we wanted to have a broad upLIFT model, but then also start looking at, are there specific high areas of focus that we could focus on? And one would be groups, and one was teens. So the group is, again, a licensed social worker, group virtual sessions, because you can't get everyone to come to a Starbucks or a library or a YMCA. It's much harder. So we did it all virtual. And again, I'll show you some of the feedback and some of the data that we have from this. And that, again, part of this is, the goal is to say, moms, you're not alone. Other people can give each other feedback, can get some bonding, can sort of see that they feel this sense of the challenges that they're facing as a new mom are felt by others. And then the teen, same sort of thing, a licensed social worker, 16 specific. And these were tailored more towards teen needs, because there's a lot of teen needs that we identified over the course of this. Again, up to 8 sessions, but this was really one of the big components where we started identifying basic needs, that many moms, particularly teen moms, needed help with food stamps and their driver's license and finishing their education. And so we developed a whole suite of community health workers dedicated for community connections. It's sort of like, from the healthcare perspective, it was case management, but for all social things. It was like, are you about to get evicted? Great. Call us and we'll see if we can help you get temporary housing. Your car broke down. Let's figure out how you get your car repaired. We had money from, again, philanthropy, that we could give money to people. Your rent is due. We can give you $200 and we can help you pay your rent. And so these community connections, that the goal wasn't to take over for the mom, but to really be a little help when moms struggle. And we found teens to be a particularly high-risk group because of the instability that in their lives. Again, these were the modules, the 16 modules that we were developed. Again, they were based largely on what we had done with our partners at the University of Houston, but all of these were specifically developed by our maternal psychiatrist and maternal psychologist colleagues, who, again, we use some of our funding to say, we think this is important. We'll pay you. We want you to be part of the team. We want you to help us to develop this. And they are phenomenal. This is an example of what a virtual teen visit looks like. The social worker, Lorena, at the top. Lorena is just absolutely spectacular. At the top, we'll work with the teen, go through the worksheets in real time, help the mom answer some of the questions, and then begin to give mom strategies on how to address some of the things that she is struggling with. So the teen moms, we had about 315, about 2/3 completed. The demographics you can see largely Hispanic. A third were solely Spanish speaking. So this was a group that we thought was really not getting reached. This was a group of moms, teen moms, largely Spanish speaking families that were not getting reached. And you can see 18% were enrolled before the birth. So they were enrolled early. That was fabulous. Like, we rarely get those, and we were very excited. And you can see that 74% did not graduate high school. Excuse me, 47% did not. But we also identified everybody we have in our intake. We look at what are their basic needs. And so you could see some of the basic needs: housing insecurity, food insecurity, transportation, healthcare, access to healthcare. They're disenfranchised from their parents, so they don't have healthcare. They don't know how to sign up for Medicaid. Like, we can help you with that. Like, that's what we're supposed to be here for. So I think we learned a lot of what were the needs by asking them. And then you can see the bottom right corner, almost half had 3 or more of those. And so you can see how hopelessness sets in, where I have all of these problems and I don't know where to start. Well, here we go. We can help you start. And I think that was where our framing. So we then looked at, we do a lot of surveys, unfortunately, because we really want to see where are we doing well and where do we have areas for improvement. Lots of improvement: depressive symptoms, bonding, maternal self-efficacy, social supports. I feel more connected to my neighbor. I feel more connected to my family. Family functioning, nurturing and attachment, and concrete supports. Concrete supports really is like, I now know where the DMV is. I now can go to school regularly. I now have a counselor. Like, concrete things, not just I want to do this, but this is what I know. And it really found that to be really valuable. Some of the quotes, and then I can go through this pretty quickly. To help me build my relationship, my family, feel better as a mother, feel better mother because of it. The red one was one that came very, very early and was really powerful. I was literally going to end my life until upLIFT and the social worker came to my life. She held my hand and told me everything was going to work out. Like, that's the kind of stuff that you like to see. You like to see, well, let me rephrase that. That is valuable. Like, we don't want women to be, or moms to be, that despondent, but we want to be able to say, if you are, we have a strategy that could be helpful. And then a lot of the other quotes are all about, this has been transformative to me as a mom. And that to me was really, really very heartening. And all these were early on. Some of these were in our pilot program. And so we do have individual intake forms. There's the upLIFT in general. There are QR codes. And again, you'll have access to these slides. There's an overall upLIFT for moms, Baylor College of Medicine.edu. Again, all of this is free, English and Spanish. And it is all, again, the overview for the groups, again, 11 weekly sessions that are all virtual. There's targeted content. There's less flexibility in the sense of we can't just, everyone's going to have different needs. So we have a very standard curriculum that we went through, again, with our maternal psychiatrist and maternal psychologist. What are the big buckets we need to touch on in these areas that everybody can be on the same page for? And then these are the topics that our group sessions would take, slightly different: motherhood and identity, everyone is emotional, mindfulness and stress reduction, sleep management. Maternal fatigue was our biggest concern. Like, moms are stressed. They have to do their regular jobs, or they have to go to school, and then the baby's there. And so the maternal sleep was really a huge area of focus on how do we get moms to address their fatigue and despair. Again, a lot of the feedback we got were very similar in our group sessions. And then the eligibility were pregnant or postpartum. For the upLIFT group, we want to spread the net wide, so you can have up to a 3-year-old. For upLIFT, which is targeted and mostly by our funders, pregnancy or postpartum women up to 12 months. So you have to have a baby in the household that is your baby in the first year of life, and you're eligible. And the symptoms are just reasonable. You have to have symptoms or have reason that the mother has depression or anxiety. We've also been really careful not to say this is for everybody. Like, if you check yes on number 10 on Edinburgh and you're suicidal, we're not the strategy. If you have a high score and we have 20 or higher, we're not the best first step. Like, we can be part of it, but we need to get you to a psychiatrist or get you to an emergency department. Like, so we have all of that built into our protocol, where we talk about this being for mild to moderate postpartum depression or maternal mood disorders, and not for the severe or suicidal or homicidal. Like, that's not what this is for. And we're very intentional on that, because we don't want to pretend like we're everything to everybody. But given that for this area, 13,000 women, 14,000 women a year have this problem, we think that it's more than enough that we can do this. So upLIFT group started in 2024. It's 182 families. The upLIFT overall started in 2022. Remember, we got some funding from the state, so 403 individual families. We target the demographics, again, 55% Hispanic, and a third are solely English speaking. Our data show postpartum depression, postpartum bonding goes up, maternal self-efficacy goes up, family functioning goes up, social supports goes up, and then maternal depression goes down. We right now service the main counties in the greater Houston area, which is Harris County, and then the surrounding counties. These are basically, if we look at upLIFT in general, these are the three main programs. There's a primary upLIFT, there's upLIFT Teen, and upLIFT Group. And it really does fit into our bigger model. So again, upLIFT is the top left corner, but we also say we want to have a variety of other things available, not just for postpartum depression moms, but in general. And so we have a variety of services. The very bottom one, which I think is really the most important that I've learned that we have least attended to, is the community connections. And the community connections is, for those who are familiar, this is Maslow's hierarchy. This is number one on the bottom. This is sanitation, security, safety, food. It is the basics. And we've realized that many moms and many families struggle with that. And before you can get to the top of Maslow's hierarchy, where you do self-actualization and decision-making, I need to have food. I need to be able to get my water running. I need sanitation. I need a roof. And so we really do embed that in all of our programs. And we have now 7 community health workers that are just dedicated to not just, here's the telephone number, but okay, I will come to your house and you and I together will fill out your Medicaid form. I don't know if any of you have tried to fill out the Medicaid form. I'm a fairly smart person. I can't do it. I cannot do it. It gets rejected. So it is a difficult thing. So we have a dedicated community health worker who used to do this for the state. So she's really helpful. And I need to go to my driver's license. I need to get it renewed because I just turned 18 or I just turned 21, and I don't know how to get there. I don't know where it is. We need to help you do that, not just saying you should do that. So that's really where we do focus referrals, we do application, and we direct assistance. We have a certain cap of money for each family per year. They call us and say, I don't have, all the formula I bought with my WIC has been spoiled because I got flooded or something like that. I need $100 to go get some more. Great, we can give you a gift card and you can go buy your formula. We can buy you a pack and play. We can buy you a crib. We can buy you a stroller. We can pay your rent. We've paid people's gas for their house and gas for their cars. But we have a cap. This isn't free money. This is part of our ability to help you with some very immediate, small micro, and they're not loans, they're gifts. And so again, a third have food insecure, a quarter have housing insecurity, a quarter don't have access to health care, 20% have unreliable transportation. My baby has a fever. I can't get to the doctor or the emergency department. I have to call 911. And so they don't. So how do we help with that? So this is part of our strategy. So again, we have through a variety of sources a total of about $138,000 that we've given out for food, safe place for the child to sleep, so a pack and play or a crib, infant items, transportation, and utility bills. So that stuff is really critical to all of our programs. We've embedded that in all of what we do. The other programs that we thought was really important was upWords. And so upWords is a language and early brain development. And it really is not postpartum depression, but it's the same sort of idea. We take kids who are really young with their moms, and we work with them on parenting skills, parent support. Again, the focus is language, communication, interaction, what now is largely referenced as relational health. How do you communicate? And we developed this, one of the earliest programs in 2017. And it really is a really comprehensive program. Every family gets a language Fitbit, which is that top left picture that measures every vocalizations from the mother as well as vocalizations from the child. And then what they end up getting is every week, it's a weekly program, they get a feedback of to how much are you talking, how much conversational turns are there, how much is the child vocalizing. The idea is to say you are concretely, objectively impacting your child's ability to speak, language, communicate. And that was to give this concrete data. The families are like, every week I look forward to seeing how well I'm doing. And that's really what we want. And then one of the cornerstones of what we do, and you can see in the far right, is we give out a ton of books. Everybody gets books. We give out tons of books. We've given out about 80,000 books over the past couple of years. And again, so we have this upSTART model. upLIFT is the top right corner, the upWords programs, the community connections, and then we developed a universal home visiting program with community health workers, a light touch, loosely framed on some of the stuff that we're doing, but we wanted to make something that was universal. Everybody gets this, and it's not targeted for a specific need. So we have universal home visitation. Some of the content is needs and goal setting, advocating for your health, healthcare partnership, thinking ahead. So part of it's sort of the basics. Like a lot of these are just first-time moms, new moms, and they get a community health worker that will meet them in the clinic when they have their baby. Sometimes you meet them in the hospital when they deliver and help them prepare themselves to be a new mom and focus on a lot of the basic things. And again, it's a community health worker, lighter touch model. And each of these programs have their own separate entry, different QR codes, dedicated enrollment. The goal is to say you can pick and choose. And once you're in, then you have access to all of this. So it's not in isolation. You can then, if you get into the upLIFT group and you want to do more and more work on parental behavioral modification of the child, you can easily switch over into upwards to squared or upwards bridges, which are other models of focusing on behaviors of children. And so we have our overall, this is last year's data, 2024 data. We serve about 1,500 families annually. Again, all of this is free, no cost at all. Much of it is in your house or in a local area, libraries. We love libraries and YMCAs and civic centers, or all virtual. So upwards, last year we have given out 82,000 books. We serve 45 counties, 200, because now we can do it virtually, 248 zip codes in almost all of the state of Texas. 45 counties, I know there are a lot of counties that don't have a lot of people. And again, largely Hispanic, and you can see 40% are solely Spanish speaking. So this is a population we think is not being attended to, and we're trying to attend to them. These are our upLIFT numbers, again, since we started in 2021, 2022, 315 moms, 2/3 have completed. The average number of sessions is 6, so people are sticking with this, and those that find this valuable, they're staying for 6 sessions, 6-hour-long sessions. And so again, 1/3 are Spanish speaking only, and these are some of the data. Our UpReach model, 500 moms. This is universal home visitation by a community health worker. 82% finished those with an average number of visits 6. So these are trying to reach, and really once they get in, our people are so fabulous that the moms find this really valuable. They use this as really valuable. And what we've seen, just even without our social worker for upLIFT, we find depression going down. They identify concrete supports that they're providing and social supports. And then overall, for our basic needs, this is that community coordination. Almost 3,000 families have been screened for basic needs. We've referred to, you can see, 4,000 families to 1,300 families for our community programs. 715 have gotten cash, gift cards, and our focus has been on food insecurity, housing insecurity, health insurance, unreliable. These are the basics. This is Maslow's hierarchy. This is public health. This is what we need to do before we get families to, why aren't you compliant with your medication? I need to take care of some of your basic needs. And a lot of families need that. And I speak on this only on behalf of the fabulous people who are doing the work. I get to say nice things. I get to occasionally get credit, but really, this is really great people. All the people who are working with the moms, they're so dedicated. They really are fabulous people. And if you ever get a chance, we'd love to have you come and visit with them. They're really the kinds of people that are doing really the, I hate to say it, but the Lord's work here. This is my contact information. I'm happy to take any questions. My emails are quite straightforward. It's my last name at BCM, Baylor College of Medicine.edu, or my last name at texaschildren's.org. And I'm easy to be reached. And with that, I think we have our community continuing education QR code for those who may need that. And I'm happy to take questions, either, I don't know if you can unmute or write them in the chat. Thank you for allowing me to. Yeah.
So that was a fabulous presentation and really such important work. So thank you for sharing it with us. I just wanted to remind you, you can drop your questions in the question and answer. And I see several people are doing it already, but feel free to use the reaction buttons. Those are always very reinforcing for the speaker and for all of us too, just to see where we stand. So, and I did want to say the talk and the slides will be archived, so you can access that. First question is, were there cases where participants' health insurance weren't able to cover a part of this interconnected maternal health care model? If so, could you please share how your team supports these people?
That's an excellent question. And I would really want to emphasize, all of this is free. We don't take insurance. We don't bill insurance. We don't ask for payment. All of this is free. You get the social worker, you get the community health worker, you get everything completely free. And it is something that we felt very strongly that we didn't want to dip into that. We didn't want it, we wanted to minimize the barrier to entry. And so the challenge is, if you do need a psychiatrist, like, we are always mindful of escalation, which rarely happens, but we're always mindful of that, or access to a pediatrician. We have a clinic that is under our division that we can do some medical stuff as well, but we are not a medical home. We want people to be integrated. So if you don't have insurance and there is a need for that, we have someone come to your house and help you fill out the forms so that you get on the insurance. And again, to answer the question directly, none of this is billed, none of this is insurance, none of this has a cost to the mom.
Right.
Because we have good funders, and that's, this is, again, we in essence, we wanted to think of moms need a safety net, and there is no safety net. And this is as close to a medically oriented safety net. We're not a social services agency, but we recognize the value of those things to moms and babies. So we do some of it, but we're not a social services agency, and we do need to have some form of safety net.
Great. Love that answer. So another question is, you mentioned nurse-family partnership. How does upLIFT differ?
That's an excellent question. So for those who may not know, nurse-family partnership is a tried and true home visiting model with licensed nurses started by David Olds in 1978 in upstate New York. And it has gotten lots of very good data. Baylor College of Medicine has a nurse-family partnership program. And we recently have taken over the administration and running of it because it sort of fits with a lot of the things. So there's a couple of differences between the two. First and foremost, the Nurse Family Partnership has a much more, I wouldn't say restricted, but targeted enrollment eligibility. Teen mother, first time pregnancy, and they have to be enrolled before the third trimester. So right there, that's really hard. So a second time mom is not eligible for a Nurse Family Partnership. So the first is the eligibility. The second is the criteria or the curriculum is very different. So upLIFT is really intended to be short. It's really intended to be something that is universal, and that's Nurse Family Partnership isn't. And Nurse Family Partnership is a 2 to 3 year program that really is intensive. And that's not what we wanted to do. We wanted to get something more universal for everybody. So upLIFT is 8 sessions social worker. Nurse Family Partnership is 2 years RN. And they both have strengths and weaknesses. upLIFT is anybody at any point in time who have symptoms or positive Edinburgh, and we will see you for 8 sessions, and it's by a social worker. And so there is similarities, but the targets are different, the delivery of different, the eligibility is slightly different as well.
Yeah, one of the things I think that's really important is going to people's houses. Because I know, like in Austin, what's happening is a lot of the services tend to be central, and people are moving out as housing prices go
Totally.
up.
Yeah.
So, anyway, I think that that's real important. And Houston's huge. So,
Yes, it is. Yes, it is. That's been one of our biggest problems. And so what we sort of thought would be a problem, but we didn't really appreciate how big a problem is transportation. We are geographically a big place. And so the other thing is Houston, Texas in general, doesn't have a very good public transportation system. So there are areas that in Houston that are just not well served. And so if you don't have a car or access to a car, your ability to get your groceries that day, your ability to go to your doctor's office, your 6-week, postpartum check, like that just drops dramatically. So these are challenges. Like we don't have the solution to housing or the solution to transportation, but our first step is, okay, let's recognize what are the challenges, what are the obstacles, what can we handle, and what can we find community partners to handle, that we don't have to own it all, but we're the tip of the spear. We should be part of figuring this out.
well, it's interesting because I think a lot of the things you mentioned fall into the category of non-medical drivers of health or
Totally.
social determinants of health.
Yeah,
You kind of have to have those basic needs met. Um,
totally agree.
yeah, we also talk a lot about food deserts, but some of our work too is talking about transportation deserts, and
Yeah,
Texas is known for having transportation deserts as well.
totally. It's really.
So, more questions from the
Oh, okay,
audience. Are
good.
there any programs that serve the same population of mothers and children that you've collaborated with?
There are some through libraries. We do a lot of early education. There are some through the YMCA's. There's the Dolly Parton Imagination Library, which is through the YMCA. So they do a lot of literacy stuff. So we refer a lot of families to them. Again, we really see ourselves as part of the solution. Healthcare is a bad rap of not being able to collaborate very well. Our mindset really is if there's gaps, we'll be the ones to try and fill those gaps. But if someone else is doing that, we will gladly hand those over to you. So we're not therapists. So we find those who do therapy for low resource families, the Harris Center. We don't want to do things that people are already doing. So we try and find nonprofits, Mental Health America of Greater Houston, or YMCA's do a lot of parent support programs, and we are really big fans, and we refer a lot of families to them. If there are specific programs, we actually have people out there trying to say, okay, who can we work with? And there are a lot of overlaps. We tend to skew heavily medical because we are a children's hospital and we are a medical school. So we tend to skew that. We want to work more with schools because these are kids, younger kids who are preschool, Head Start, early Head Start. We have a collaboration with one of the neighborhoods here in their Head Start building where we have all of these programs that are delivered in the Head Start building. Like, we want this to be something is easy to get to and where the families are. And that's why, again, why I started with our study to show there are huge gaps and great gaps in who deserves care, and they're just not getting it. So maybe we should go to them. And that sort of was the mindset of what started a lot of this work. And I have to admit, 15 years ago, I was quite resistant to home visitation. I thought it was clunky and expensive and not useful. But I've really realized, like, we can't just sit here and expect people to come to us when there are challenges. Like, we need to go out there. So that has really been a huge value to us, is to be able to go out there and find those partners.
Great. So we have several questions from the audience. Do patients have access to community connections if they solely participate in the support group only? I also want to thank you for continuing to do this work and give me an opportunity to work with this population by hiring me for the HOPE program at UT Health. I agree, Lorena is amazing.
That is so funny. Yes. Once you get into any of those programs, you get everything. That's sort of the goal. Like, we want to have a focus. It's not just a hodgepodge. We want to say, what are your immediate needs and how can we help you? But, oh, by the way, we have these other things. So community connections, which is sort of the basic needs, everybody has access to. And that's partly now become problematic because we've realized lots of people need help. And we spend a lot of time. We have, again, fabulous people. We have dedicated faculty who are writing grants, and we send out 20 or 30 grants a year just for basic needs support because we want to be able to be helpful. So everybody gets access to everything. It's not a hodgepodge. We want to say, okay, what is your need that you want us to help you with? And while you're here are other things you can do. And yes, I do agree that Lorena is wonderful. So
that was nice. So another question is, where can this be found on the TCH website? I tried to find info to share with my yard guy and couldn't find it. So
if you look at the Division of Public Health Pediatrics on TCH's website, it'll have access to all of these it'll have links to all of these programs. I appreciate that question. We are currently working on, we don't have a very accessible public-facing pages on either Baylor or TCH, and we're actively working on how do we synchronize both of those, and that the public-facing face is easily accessible. So thank you for that question. If you email me, I'm happy to send you all the flyers, and I can send everybody our booklet. We have an upSTART booklet. It has all of these graphics and all of the information in one PDF, and I'm happy to send that out for people to send far and wide.
Well, and after the presentation, everybody who signed up will receive an email with the information, and so they can get your email then.
Yeah.
So someone asked, what's the best way to refer women to this program? I'd like to share this great resource.
So I think the best way is the QR codes or the links. The links are REDCap, and REDCap, for those who may not know, is a standardized database that's free that most academic institutions use. We don't track anyone's data. That's a way that we can have a standardized application form. If someone applies and they don't enroll, we trash everything. Like we try and it's all HIPAA compliant, it's all standard, and we have a dedicated REDCap. So REDCap is basically like the Microsoft Forms. It's the same sort of thing. It's just a platform that many academic institutions use. So the QR codes will take you to the REDCap, or there's a REDCap link, and then each of the programs have a dedicated email address. And in the materials I'll send you, it'll have all of that. It'll have the QR codes, it'll have the web links, and it'll have the email addresses and the telephone numbers for people to call. We tried to make it on the front end as, again, a low bar to entry as possible.
Thank you. So the next question is, do you work at all with mothers on finding affordable childcare, which is another barrier and overwhelming?
Yeah. That is a fabulous question. I'm sort of bummed you asked it, because to me, it's one of the biggest challenges. We did a study where we looked at asking people in clinic, what are the needs of the families that you serve? And then we asked the families what their needs were. And the biggest difference was families across the board said access to high quality or even reliable childcare was their number one concern. And none of the medical people even put that on the list. And so the idea that childcare is a need is a really big problem. Because healthcare doesn't recognize it as a need. It sort of sees it almost like a convenience. We try to really focus on that. We're trying to get money for childcare subsidies. Clearly we're very interested if the state wanted to expand or actually grow childcare subsidies. Really important. There are some low resource childcare agencies that we've worked with that we refer families to. Sometimes it's difficult because geographically there's not a lot of them. And so transportation, if it's a problem, becomes an issue. But I do agree with your question, like that is a really big problem. And I think if we want moms to go back to school, if we want moms to enter the workforce, childcare is their number one. As anyone who has kids will remember during COVID, when everyone's childcare closed down, no one could show up to work. And that was a huge problem. And that to me was, again, an area that we're working on. And I agree, if there are solutions, if people have strategies, I am open to it. To me, that's one of our biggest needs.
I agree. And it's just essential that you have childcare and quality childcare for the development of children here. So another question, is there a Healthy Start in Houston that you can partner with that has services that are similar to upLIFT?
Yeah, so that's actually fascinating, because that's how this started. The Healthy Start site that was in Houston at the time was at the University of Houston. So what we did is, we're interested in this program. So we reached out to them and said, do you want to work with us? And they actually were our initial partners on developing upLIFT, because they helped us develop what became upLIFT by using problem-solving tools for postpartum depression. That's what our study was, and that was based upon the Healthy Start program at U of H that didn't get refunded, and so that now there's a gap, and so we are open to that. Like we are thinking about maybe we should apply for it. We don't want to do everything. We want to spread the team wide. So we're working with the U of H folks to see if we can help with a reapplication. But there was Healthy Start that we worked with, and unfortunately that went away. And we'd love to continue that. We do work with groups like the United Way in Houston. One of the big child-centric, child-supporting organizations is the Children's Museum. So the Children's Museum has casts a long shadow. So we send a lot of our books through the Children's Museum. We do a lot of education and parental outreach through the Children's Museum. So we're quite open to finding whoever wants to work with us. We'll be happy to give you the materials to do it. We funded through Harris County for the same thing, and we worked with the Children's Museum and the United Way and March of Dimes. Like we want to work with people who are out there.
Well, that's all we have time for today. Unfortunately, I have a lot of questions for you as well, Dr. Greeley,
Excellent.
but I can follow up later. So if everyone could please just join me in a round of virtual applause for Dr. Greeley. This has been a fantastic project and fantastic presentation. So the information there for nursing CEUs, you can see the QR code. So please download your certificate before exiting the evaluation. So you also need to complete that online evaluation. So make sure you do it. We're also offering CHESS and MCHESS credit, and you'll receive an evaluation within 1 week following the webinar if you indicated that you want those credits. So please follow up. We're happy to provide them, and really happy that Cizik School of Nursing participates with us on this. And then, as I mentioned, we have a couple of upcoming webinars. We do have several webinars. One is Fueling Healthy Futures in the First 1,000 Days of Life. So it's going to be talking about feeding children in the first 1,000 days of life. And then we'll have a webinar on navigating holiday meals. So culinary strategies for blood sugar control. November is National Diabetes Month. So those are upcoming. And then please feel free to visit our website, msdcenter.org, for all of our resources. And as I mentioned before, this will be archived, this webinar, and the slides will be available. And then we'll be sending information to all registrants for this as well. So you can follow up, and you'll be able to contact Dr. Greeley and access his programs through the QR codes as well. So I'd like to thank you one more time for attending. It's been great, and I'd love to thank Dr. Greeley for sharing his time with us. He's super busy, and such wonderful programs. We're really happy to spread the word.
Thank you. I'm thrilled to have been part of this. I'm such a fan. So thank you all.
Y'all
Everyone
take care.
have
Have a great
fabulous
day.
day. Yep. Bye.
Bye-bye.